Hello, everybody. Welcome again. I was going to get started since it's right at 12 o'clock. So to kind of start off, I'll introduce myself. So my name is Abigail Yancey. I'm a graduate of Stillcup as well, graduated 0203. Currently, I'm faculty here at the College of Pharmacy, and I do my clinical practice at St. Mary's Health Center here in St. Louis. So my general practice is internal medicine, but I do have an interest in GI liver and currently lecture at the college on liver. So today my goal is to kind of give you a brief update on everything hepatitis C that's going on. As we know, it's constantly in the news now because of all the new medications and things like that. So that's pretty much what we're going to talk about today. So the goal is really just to review the current landscape of hepatitis C therapy. We're going to discuss the most recent FDA-approved agents. And when I say most recent, we'll kind of stick with 2016, so pretty much everything in the past 7-8 months. We're going to evaluate what needs to be considered when starting a patient on therapy, and then also discuss some helpful tips for pharmacists when we're educating or even just speaking with a patient that has hepatitis C. Just want to let you know there is a place to ask questions, so if you have any questions, don't hesitate to type them in, and I'll try to get to them as soon as I can. All right, sorry about that. Computer's not working. So hepatitis C. More than 3 million Americans are actually infected with hepatitis C. Unfortunately, about 50 to 70% of patients don't know they are infected. Hep C alone is estimated to cause about 17,000 deaths per year and is currently the most common cause of liver transplant. So we think about that scope alone with the amount of deaths and the cause of liver transplant. It is an extremely expensive disease once a patient goes on to more of the end-stage liver. Interesting enough, about 75% of those infected are baby boomers, meaning they were born between 1945 and 1965. And they're actually about 5 times more likely to be infected than anyone else. We don't really know why this is the case. The big thoughts is we didn't know hepatitis C was a thing back then, and so it's much easier for them to become infected. We weren't able to test the blood supply at that time, so even patients that had blood transfusions and things like that could become infected. So there's a lot of different reasons for this increased number. Interesting, looking at the stats for Missouri and then also Illinois in a second, about just short of 100,000 patients in Missouri have hepatitis C. For baby boomers, this ends up being about 63,000. Interesting enough, about 75,000 patients are Caucasian, about 20,000 blacks, and about 2,000 Latinos. So we often think of it as a pretty major thing, especially in the city of St. Louis. It's very common for my patients to come in with chronic hepatitis, so it's definitely something that we'll see. In Illinois, the stats are actually pretty much double what we have. There's about 200,000 patients with hep C and about 136,000 baby boomers and about 137,000 are Caucasians. So once again, the numbers are pretty skyrocketing with the amount of patients. And once again, we have to emphasize these are the patients that we know about. Only 50 to 70% of patients don't even know they're infected. So our numbers actually are going to probably be even higher than this once we know what patients are infected. So back when we were in school, or most of us were in school, treatment consisted of interferon and ribavirin. The bad thing about interferon and ribavirin is they don't necessarily attack the hepatitis C virus themselves. It just tries to help our immune system attack and protect our body and prevent the virus from replicating. However, due to the numerous contraindications, all the adverse effects, the extremely long duration of therapy, and low rates of efficacy, patients on PEG interferon and ribavirin might have efficacy rates of 30–40%. Because of this, only about 15% of patients underwent treatment. So it was usually patients when they were starting to get more end-of-life, end-stage liver disease, or the liver just couldn't handle the disease burden anymore, that we would put them under treatment. Many patients, once they were treated with that, would swear off ever being treated again because the adverse effects were so horrible and uncomfortable for the patients. Luckily, in the past decade or so, we've had major advancements in the treatment of hepatitis C, and that was the development of direct-acting antiviral agents. These agents themselves will target specific proteins of the virus to disrupt the viral replication. These therapies have been a huge milestone in curing HCV, and we'll talk about curing HCV in a second. But here's just a brief demonstration of the hepatitis C virus itself and kind of where our main drugs are able to attack and really prevent the RNA replication and the viral assembly within the hepatitis C virus, which then prevents the virus itself from replicating. So we're able to actually stop the replication process of the virus. So as we know, antiviral therapy is now the cornerstone of treatment. It's very rare to see patients on PEG interferon and ribavirin. Now the goal of therapy is to eradicate the hepatitis C virus RNA. Once we eradicate that virus, the hepatitis C is gone. We predict this by attainment of SVR. SVR is sustained virological response. Our goal SVR is usually measured 12 weeks after a patient is treated. If the patient has achieved SVR, meaning no HCV RNA is present, then they are likely cured from the disease. SVR is associated with a 97 to 100% chance of being HCV RNA negative during long-term follow-up. Hence, our patients are cured. Because these new therapies have high rates of SVR, greater than 95% with the majority of the drugs, unlike what we saw with PEG interferon, where it could be 30, 40, maybe 60%. So because of these high rates of SVR in these patients, most patients are able to be cured. And this is fabulous news because being cured and having to assess our SVR rates will decrease our all-cause mortality, our liver-related death, the need for renal transplantation, which is a huge cost savings, decrease our hepatocellular carcinoma rates, and other liver-related complications. This alone could be a huge financial savings for the United States and, of course, our Medicaid budget. So what therapy options are out there? So since 2013, we've had many drugs pop onto the market. I'm going to focus briefly on each of these meds, and then we'll kind of get more into detail on the more recent ones. So sofosbuvir and simipravir were the ones that first came out in 2013. Sofosbuvir was approved for genotypes 1 through 4. However, it's initially needed to be used with ribavirin or interferon. So we still had all those ADRs with it. It was a great drug. It was able to help shorten the therapy. The problem was patients still had to take the interferon and or ribavirin. Simipravir was approved for genotype 1, but it had to be used along with sofosbuvir. Oftentimes with the sofosbuvir, we'd also have to add on the PEG, interferon, and ribavirin. So the kind of perk of these meds is we were shorter duration of therapy, but some patients were still having to do the PEG interferon. In 2014, probably one of the biggest guns came out for us, and that was Harvoni, the combination of the sofosbuvir and the lidosvir. This was a huge addition because it was the first once daily only pill for the treatment of genotype 1. So genotype 1 is going to be pertinent in this talk because the majority of hepatitis infections in the United States are actually genotype 1. And we'll talk a little bit more about genotype in a bit, but just kind of keep that in mind. Vicirapac was also came to the market right after the Harvoni did. This was only approved for genotype 1. That thing, it has many limitations, many drug interactions. It actually is, patient has to take 3 tabs in the morning and 1 tab at night. So it's kind of fallen out of favor, although it is an option that we have. The other bad thing about this one is you cannot use it in patients with a decompensated liver disease, so that is kind of pulling out some of our sicker hepatitis C patients that can't be treated. In 2015, Declenza came out, and this was a great improvement because along with sofosbuvir, it was our first only oral option for genotype 3. So that's kind of where its claim to fame is. Genotype 3 is not very common in the U.S., so won't get as much use, but it is the first oral therapy when used with sofosbuvir. Tenofovir was approved in 2015 as well, and this one is a great addition, mainly because it's the only oral therapy to treat genotype 4. Once again, not as common in the U.S., but it will have its role. So the tenofovir for all oral for genotype 4, and the deflenza with sofosbuvir all oral for genotype 3. Most recently, in 2016, we had Epclusa and Zepatier both approved. Now, both of these agents have all oral regimens, but I'm going to talk each one a little bit in more detail on the next slides so we can talk about the little nuances with each of those. So Zepatier was approved on January 28th of this year, and it was approved for genotypes 1 and 4, including genotype 1 patients on hemodialysis. So this is pretty much one of its big kind of claim to fame, because we know we can use it on patients that are on hemodialysis, and was actually approved with the breakthrough designation because of this. SVR rates in this patient population, great. Genotype 1 patients had about 94 to 97% SVR, and genotype 4, 97 to 100%. So the drug works great. One pill taken once a day with or without ribavirin. Patients with cirrhosis do better with the addition of ribavirin, so that's right now the recommendation for that. One concern we do have with this Zepatier is about 1% of patients will experience a 5-fold increase in their liver enzymes. The interesting thing about this, it usually occurs right at or after 8 weeks of therapy. So if a patient is on this therapy, we definitely want to keep a close eye on their AST and ALT levels just to make sure everything is looking okay. And if they do increase, we need to consider removing therapy on those patients. It is also contraindicated in patients with moderate to severe liver disease, so your child PUC and above. You need to be concerned, especially on those patients that have had hepatitis C for a bit longer and have some liver issues because of it. As I mentioned, in 2014, Harvoni was approved and was a great drug. Luckily, we recently had some more indications, our updated approval on it on February of this year. So Harvoni with ribavirin was approved in liver transplant patients without cirrhosis with genotype 1 and 4, and compensated cirrhosis, child PUA, and Geno 1 decompensated cirrhosis, child PU B or C, including patients that have undergone liver transplant. So the big thing is just we've had expanded the patients that would be appropriate for Harvoni. And last but not least, the most recent was June 28, 2016. Epclusa was approved, which again is a combination with the sofosbuvir and velpatasvir. Have to get that one out. And what's great about this one is the first agent that can treat all genotypes of hepatitis C. So right now we know there's probably about 7 to 12 different genotypes. 1 and 6 are kind of the big ones that we see. Interesting about this one is in a study, one of the patients was actually misclassified as having genotype 2. After this study, they realized the patient actually had genotype 7, and they still were cured with this drug. So this is really our first all-oral pan-genotypic agent that can treat and potentially cure all types of hepatitis C. It's taken once daily with or without food for 12 weeks. Now, for patients that do have decompensated cirrhosis, they do better with the addition of ribavirin if possible. Headache and fatigue are the most common adverse effects. About 10% of patients will have that adverse effect. Most of the patients can tolerate the drug, so the amount of patients that have to stop taking therapy is actually very minimal. There are some contraindications we need to consider. The big one is if the patient's also taking a statin. It is contraindicated with atorvastatin greater than 20 or rosuvastatin greater than 10 milligrams. So just if you see a prescription for that and your patient does have some CAD risk factors and they're on statin, we just want to make sure that there aren't doses greater than this because of increased risk of liver issues. Medication is pretty expensive, and I'll talk more about cost in a little bit, about $75,000 for a 12-week course. You can look below. I kind of included a little chart of the different SVR rates for both of these drugs. So genotype 1A, 1B, as we know, genotype 1 is most common in the U.S., we had SVR rates of 98 to 99%. So this is huge in this patient population. There was also a sub-study looking at patients with the ribavirin and decompensated cirrhosis, and they also had SVR rates of greater than 90% in this population. All right, so we have all the therapy options. So the big thing is, how do we choose? How do we know which one to use? Because there are so many options out there now. There's a few things we have to think about before we start a patient on therapy. The most important thing is the genotype. As I mentioned before, HCV has up to 12 different genotypes. Unfortunately, unlike other hepatitis viruses out there, hepatitis C is not able to proofread. So during the viral replication stage, sometimes there's going to be an error in the replication, which leads to the different genotypes. In the US, as we talked about, genotype 1 is the most common, about 75%, and about 20 to 25% of patients are genotype 2, and then the rest of the patients kind of go through genotypes 3 through 6, at least the ones that we know of. Next is stages of the disease. So we need to go back and see, does the patient have cirrhosis? Is it a compensated versus a decompensated cirrhosis? Because our therapy choice and duration of therapy and the addition of ribavirin to our therapy will depend on that. Prior HCV treatment, we are now starting to see many patients that might have failed PEG interferon and ribavirin choose one of these oral agents for that. Drug interactions, as I mentioned, especially with some of the older drugs, there's a lot of drug interactions. So they are often metabolized in the liver, so we have a lot of P450 interactions. So you have to definitely look at the patient's other medications to see which would be most appropriate for them. And unfortunately, probably one of the reasons we hear about Hep C so much in the news lately is because of the financial implications as well as the insurance limitations with these drugs. So many insurance companies will only cover one of these such agents. So finding the best agent for a patient can be difficult. And then, of course, patient preference. And, majority of our patients will probably prefer the drug that's taken once a day, one pill, and they don't have to worry about food or anything with it. But that's definitely one of the things that's going to come into play is the patient preference. Based on the research and based kind of on what different practitioners are doing, probably the two most common prescribed agents right now are Harvoni and the Epclusa. Main reason for that is they're one tab daily for 12 weeks. They have minimal adverse drug events. The main thing for both of them are just some fatigue and moderate nausea. Some say actually the nausea kind of gets better over time. Harvoni is only appropriate for our genotype 1 patients, where the Epclusa can be used for genotype 1 as well as 2, 3, 4, 5, and 6. Both of these agents do contain sofosbuvir. Because of that, you're going to see a lot of similar drug interactions as well as ADRs. A couple of the big ones I want to point out is acid reducers will decrease the absorption of these drugs, which is not always a good thing because we want the drugs to be absorbed for efficacy. So PPIs, if you're going to use PPIs with Harvoni, you need to take the Harvoni on an empty stomach and make sure your dose of omeprazole or whatever other agent you're taking is less than 20 milligram equivalent. Now in the Epclusa, they recommend actually not using a PPI with that agent. If a patient's going to take an H2 blocker, you want to encourage them to take it the same time or 12 hours after, or 12 hours apart. And then antacids they're going to want to take 4 hours before or after they take the Harvoni or Epclusa. Once again, kind of the same as rosuvastatin. You're not going to want to use doses greater than 10 milligrams per day. And it's contraindicated with amiodarone. So there's been case reports and studies that have shown that patients on the sofosbuvir with amiodarone experience symptomatic bradycardia, which can be dangerous. So major contraindication with these two agents would be the use of amiodarone. So as I mentioned, tons and tons of drug interactions are out there, way too much for a pharmacist to keep memorized. There's a great resource out there, the hepdruginteraction.org checker. Great resource. It also has a lot of HIV medications on there. So you just put in the drug name and what medications are on, and it kind of gives you a great idea of what the interactions are. Also, be cautious with any over-the-counter medications and herbal medications. Sometimes our patients don't really think about those as medications, but because of the cytochrome P450 interactions with some of these antiviral agents, herbal medications can be a big concern. Education, one of the big things, of course, is adherence. I know with HIV, we know you need to take percentage of your drugs for the efficacy to occur. Unfortunately, we don't have the same data of like what percentage you have to take for the drugs to occur. So we just want to encourage our patients to take 100% of the dose 100% of the time. Ideally, same time every day so that they get in that rhythm. Transmission risks. So if we do have a baby boomer that comes in and they're worried about spreading it to their wife, what kind of things do we need to think about it? Well, the big thing to remind them is it is blood exposure is the most common. So even things as brushing your teeth with someone else's toothbrush or using someone else's razor could potentially lead to the transmission. Illicit drugs, if your patient is still an illicit drug user, make sure they're very cautious with the IV and cocaine straws because there are plenty of data out there that even cocaine straws can pass hepatitis C virus. If their household surfaces do be contaminated with their blood, encourage them to use a bleach to clean it. Look, the data says that 9 parts water to 1 part bleach would be suffice in that. And then, of course, alcohol avoidance. Anything we can do to protect the liver is going to be helpful. So avoiding alcohol altogether is great for these patients. Weight loss, there's plenty of data out there that shows that obesity as well as like prediabetes and glucose insulin issues can worsen the liver disease, which would just make the hepatitis worse. And then avoid marijuana use. So although some patients will say, well, if I can't use alcohol, I'll do the marijuana, studies have shown that marijuana can also worsen the hepatitis C. On a side note, very interesting, there has been studies that have shown actually coffee, 2 to 3 cups a day, is actually helpful in protecting the liver with the cleansing. So if they do need something, coffee is always a great option. There's always the concern with statins in the liver, and this has been in the literature a bit more now because some studies have recently come out. So some physicians will be a little leery about prescribing statins in this patient population, especially now that we're treating so many more patients with our oral therapy. Statin are going to be a potential drug that they're going to be on. So one study recently showed that actually patients on a statin had a 40% lower risk of liver decompensation and death. Other studies have shown actually similar results in patients that have liver disease as well as specifically hepatitis C. So take-home point from this, statins appear to be safe. Of course, always more data is needed, but just because a patient has hepatitis C does not mean they can no longer take the statin. Now remember, atorvastatin and rosuvastatin dosing can interact with some of the drugs. We just want to make sure that we have that covered. But statins in general across the board are still safe to use in patients with Hep C. Aches and pains. So all through school we're taught acetaminophen is bad on the liver. Acetaminophen is bad on the liver. And it is when we use excessive doses. So we know that for sure. Plenty of data has shown that actually doses of up to 2 grams, maybe even 4 grams, will be safe to use in our hepatitis C patients. The major patients you want to caution are the ones that are still drinking. If your patient is still drinking, you definitely don't want them to take any more than 2 grams a day. And of course, encourage them, especially because of their liver disease, to stop drinking. NSAIDs, we would think, well, those must be safe on the liver. And in fact, they're really not. So although they're traditionally safe, patients that have liver disease, the NSAIDs can be hepatotoxic. So we do have to be careful with them. And one of the big complications of end-stage liver disease is once a patient goes into hepatorenal. Once their liver is failing and their kidneys are failing, death is going to be imminent. So because the NSAIDs can affect renal function, we definitely want to kind of stay away from them in those advanced liver patients. Pricing, as we know, pricing is exorbitant for these medications. I bet you weekly in the newspaper we're reading about these crazy prices that the drug companies, especially for these meds. Other studies have shown, though, even though they're expensive now, their cost savings for medicine in the future with their end-stage liver disease kind of balances everything out. One of the good things to think about, though, with our patient population is there's a lot of patient assistance programs out there. So most of these drug companies will have patient assistance programs for them. As we talked about before, the Harvoni and the Epclusa are probably the most common agents that we'll see being used. Harvoni is just under $100,000 for a 12-week supply. Epclusa is about $75,000. When you kind of balance the two out with their patient's assistance, either one could be an option depending on the patient's insurance and what assistance programs are out there. And this is just kind of another breakdown about how much we have spent on hepatitis C, and that was 2014 alone, so before we had some of these other medications out there. Definitely look into the patient's assistance programs for these patients. There's many of them out there right now, and luckily a lot of the GI clinics are aware of these, so it won't necessarily be on the pharmacist to take care of. Well, that was hepatitis C in a nutshell. I did go over time a little bit, I'm sorry, but thank you all for staying with me. If you have questions, you can email me. I should have included my email address on there, but it's just ayancy@stillcopd.edu if you do have any further questions of clarification or anything like that. But thank you so much. Have a great weekend.